Dr. Julie, University of Namur, Belgium. Julie Laloy is an assistant professor affiliated with the Department of Pharmacy, University of Namur in Belgium. She has a master's degree in biomedical sciences, specification in toxicology, and holds a doctoral degree in ex vivo and in vivo evaluation of the potential toxicity of manufactured nanoparticles, PhD. She has an expertise in preclinical assessment of nano drugs for treatment of neuronal and cardiovascular disease. Her research focuses on 3 topics, namely the development, characterization, and safety assessment of nanomedicine, in vitro and in vivo, and hemocompatibility of nanoparticles, nanomedicine, and in vivo toxicology after inhalation of particles.
So thank you. It's a great pleasure for me to be in presence after 2 years of COVID. And it's also the pleasure to present to you. It's not my work, but it's a work ongoing. It's a review I done on the field of cardiac ischemia and on the model available in vitro and in vivo. And I have the same comment that we have presented before, like drugs that are developed for cardiac ischemia don't reach the market because we have problem with the model we have on animals and on cells to have proven drugs developed in this model. So why studied cardiac ischemia? Because it's the cardiovascular disease are the global cause of death in the world. After that, we have the respiratory disease, which are chronic obstructive pulmonary disease and lower respiratory infection, and also neonatal condition. The different, so you can see here on the graph the evolution of the global cause death with years. So in the 1,000 years and 3 years ago. Sorry. So we have an increase on all this pathology that also are due to the increase of the life duration. So the cause of the death are communicable. So we have infection and parasite disease, and we have COVID. Also in this category, we have non-communicable disease, which are chronic disease. And we have also injury. So the non-communicable disease is clearly ischemic disease, which is the focus of my talk today. So while focusing on this, because ischemic disease is responsible of around 2 million of deaths per year, and it's the largest cause of death in the world. We are not equal to this pathology because men are more susceptible than women to develop ischemic disease. Women are a little bit more protect against this pathology. So we have an incidence of this pathology, which is more for the higher people, which is 60 years for male and 60 years for female. Also with the protection we have for female, but it's not the aim of this talk. And we have also some risk that can lead to the development of this pathology. So the non-modifiable risk factor are the age of the patient, the family history. We have some genetic factor that can lead to improve the ischemic heart disease, and also the sex, like I presented you before. We can also have some parameter in our life that we can modulate to diminish the risk to develop cardiac disease. So we are cigarette smoking, we are diabetes, hyperlipidemia, hypertension, and the lack of exercise. So it's something we can act on to reduce the risk to develop cardiac disease. We have also other factors that are for some of that in link with the modifiable factor, which is obesity, the stress, which is not so easy to manage, and also the consumption of alcohol. So ischemic heart disease is characterized by an inadequate supply of blood and oxygen to a portion of the myocardium. So it can be due to stenosis, it can be induced by a modification in oxygen transport, a dysfunction of the mitochondrial function. We have also a change in the energy substrate, a microemboly. We have a microvascular dysfunction, spasm, an alteration also of the platelet function in the blood, and a dysfunction of the endothelium. And it's mostly characterized by an imbalance between the myocardial oxygen supply and the demand we have for this oxygen. So we can divide the coronary artery flow by 4. So we have the atherosclerosis, which is the main cause of ischemic heart disease, and also the more difficult problem to mimic in vitro and in vivo. We have also vasospasms and vascularitis. So for the pathogenesis, we have 4 different factors that are very implicated on this pathogenesis. First of all is the wall of the stenosis or the obstruction of the blood vessels, which is characterized by an obstruction of 75% of the lumen of these arteries, which is clearly the case when we have the development of atherosclerosis plaque. We have also the wall of this atherosclerotic plaques, which can lead by a rupture of the plates, an ulceration of the plate, and also the hemorrhage of the plate that can improve the stenosis and aggravating the damage. We have also thrombosis that can play a role in the pathogenesis by the luminal obstruction when we have a clot that block the blood passage to the heart. We have also the wall of the vasoconstriction that reduce the lumen size and can also help the plaque to be disrupted. So when you contract the lumen of the vessels also diminished, and you can induce the rupture of the plate and the damage on the side, on the heart. So the cell death in the ischemic heart is due to the time of ischemia. So here you have an example on here it's in red. What's theoretically the infarctus size could be if we have not the reperfusion time. So when you have a heart with an ischemia, the treatment you have is to reperfuse the heart to give oxygen to the oxygen and blood to the heart. So if you don't perfuse the heart, you will have this type of damages with a big size of myocardium ischemia. If you reperfuse the heart, it's the curve in green, you normally prevent, in theory, the ischemia region, and you will be close to the normal heart. But in the reality, you have more something like this, because the reperfusion induces also some damages to the heart by itself. So we have damages which is due to the ischemia, but also to the reperfusion, which is also difficult to mimic in vivo model. So just to present you what is so important, what are the most problems we have with ischemia. So ischemia is occur when you have a dislodge of the plaque clot in the artery and you have an obstruction of the blood flow. The occlusion induce diminution of the nutrient and oxygen in the heart. During ischemia, the oxygen is missing to the cardiomyocyte, and you have a switch inside the cells to anaerobic glycolysis for the production of ATP. And during the reperfusion, the most aim is to give to the heart and to the cardiomyocyte oxygen to restore and to re-oxygen the cells. So what are the available treatment to the ischemia? So there is no clinical relevant therapy available until now to reduce the ischemia reperfusion damages, but some drugs have been reached different states in the clinical trials, and mostly the phase 3 clinical trials, but they are not reached the market because there are some problem with the in vitro and in vivo models. So no new therapy can diminish the risk we have with ischemia reperfusion disease. The reperfusion is used normally to solve the heart and to save the ischemic region, but they can also cause some damages by itself, and we thus need more predictive tests and to improve the success of new drugs and to develop new drugs to solve the problem of ischemic reperfusion injury. So to do this, we have a different type of model that can be developed. First of all, the in vitro model, which are on isolated cells, but also that can be more complex with in vitro 3D model, which is a co-culture, or you can also work on ex vivo model like a perfusion of the heart. And we have the animal model, but we will just show you that we have problem with all these different model to have something that is more realistic and that can be helped to the development of the new drugs to solve ischemic reperfusion. So first of all, the in vitro model. So we have first the 2D model. So we work on cardiomyocyte, which is clearly logical. Cardiomyocyte can be isolated from the heart of animal or can also come from a human, but it's not the cardiomyocyte from each individual, but it's cell line. So cardiomyocyte help to assess the direct effect of drugs on cardiomyocyte, but we also need to, it can help for the development and also for the mechanistic of the drugs on these cells. It's the 2D model help also to test a lot of therapeutics because it's the first line to assess if the drugs is suitable or not. It's predictive for the pathophysiological of ischemia reperfusion, but it not recapitulate all the complexity of the heart because it's a 2D model. So we have some, there is some in vitro model that examine the ischemia reperfusion injury in vitro, and for that they simulate the ischemia phase for the cardiomyocyte, and after they mimic the reperfusion step just in changing the cellular environment. So they put to mimic ischemia, they put the cells in an hypoxic environment, which is done by a gas-tight chambers. And you can also flush and replace oxygen by CO2 and nitrogen. You can also modulate other factors like hyperkalemia, acidosis we have also when with the modification you have inside the cells. You can remove the nutriment and increase the waste. And you can also modulate the lactate in the cellular environment to mimic the anaerobic glycolysis. After, you can put, when you have simulated the ischemia, you can after switch to the web perfusion model, and this the time you let the cardiomyocyte in the ischemia condition is clearly a critical parameter, but it's difficult to know what is the better time to do this in vitro, because the ischemic time could vary from 2 to 5 hours, which is very long, and a parameter which vary a lot. And it's the time for the ischemia depending on the cell source, the type and the maturity, and also the origin, if it's cell from animals or from human. The European Society of Cardiology work on that and recommend that the combined ischemia and web perfusion time should be selected to have 50% of cell death, to have enough cell death to mimic ischemia in vivo, but not too much to be able to have to let the cardiomyocyte to yes, I don't know in English, so it's difficult. Sorry, I have a short night during the flight, and it's not so easy to find my work. So just the cell that are not dead need to be improved to be alive. So each in vitro model need to be studied independently to determine the ischemic time for each type of cells, which is so laborious because we have cells coming from different species and also from human and from different origin. When you simulate the web perfusion, what we need to do is to give some nutriment to the cells, and also to remove the hypoxic condition, so to give the high level of oxygen to the cells. So for the web perfusion solution, we use nutrients, and we use glucose, and there is a serum-free media. We also add calcium because it's necessary to re-establish the physiological extracellular concentration, and the time after perfusion is also important and need to be standardized. The cardiomyocytes are, for most of them, derived from animals, or they can be also immortalized cells line. And from 5 years, about 5 years, we have now pluripotent stem cells, which are called iPS cells, which come from human, and they are more close to the reality. The cardiomyocyte source, so if they come from animals or from human, affect the response to ischemia web perfusion injury. So it's important to determine the predictive power of the pharmacological testing depending on the species that come in the cardiomyocyte. But it's clear that it's not so easy, and also it's not the same cost if you use human or if you use animal cells. So it's clear that people begin with cardiomyocyte coming from animals. It's also, as it's less expensive, it's able to test a lot of drugs on this. But before coming to the animal model, it's better to validate the result you have obtained on animals cardiomyocyte on human cardiomyocyte. Because we have a difference between animals and adult human cardiomyocyte on the beating rate, on the meiosis isoform, on the ITP utilization, also some electrophysiological properties that affect the cell response to IRI, and also improve the difficulties to extrapolate the result from human to animals. So to have the success of the drugs to come and to reach clinical trials. We have cardiomyocytes from different species, so rat, pigs, and rabbits. The maturity of the cells also are dependent on of the origin. And it's more relevant to work on adult animal and on adult cells than on immature cells, because immature cells are more resistant to hypoxia, so they are not a good model because they can resist. We have also cell line, which are the first line we used to when we develop new drugs. Independently of the model, we use clearly a cell line because it's less expensive and so able to test a lot of drugs. For the human cardiomyocyte, it's the ideal, but the problem is to have this cardiomyocyte, because human primary cardiomyocyte is clearly not feasible. And we have just a cell line, which is AC16, and we have also the iPS cells, which are human-induced pluripotent stem cells, which are fetal phenotype, more resistant to hypoxia than the mature cells, but it's clearly more close to the more close because it's human cells. And it could also help if you can have from the different origin, because if you buy these cells from different sources, you can have different specificities in the patient disease. So just to say that we have a lot of possibility to have different cardiomyocyte sources. The facility to use them, because the more difficult are the human, and the predictive, more you are close to the human, more you are predictive on your result. You can work on something more close, but with animals, it's isolated perfused earth, which is more easy because you can clearly see what you've done. You maintain the physiology of the earth, and you can work on the more controlled condition than in vivo animals. It's similar to the in vivo model, but you have not all the physiology of the human, because you have to isolate the earth and after you perfuse them. But you can clearly see what happened in the ischemic region here in black. You have after to decide if you work on animals. So clearly we use in the pharmacological development mice or rats, but the best model for the earth is the mini pig. So to measure in vivo ischemia with perfusion injury, what are the parameters we measure? We measure the infarct size. We can assess some plasma biomarker. We can look at the physiology of the earth. We look at the inflammation and the scar, neovascularization, and some microvascular damages. Here you have the in vivo model. So the in vivo model on rat and on mice, it's clearly required some technicity from the people who perform that. So we need a clear formation, and when you perform that, you see that the first animal you done and the last animal you done, you have clearly a difference due to the practicity of the people. So the technicity clearly can induce some bias in the result we obtain. So it's difficult to manage and to have this model on your hands. So in small company or in the academic domain, it's more difficult to have, but it's possible to have this and to develop some drugs. And it's very interesting, but we have a lot of variation due to the practicity. It's the best approach to study the hypoxia reoxygenation, but it's not the same that in human, and we have also some variation due to also the ischemia with perfusion, which is not so easy to do the ligature exactly the same between the different animals. So the animals model simulate the earth physiology, but not clearly exactly the human physiology. The pigs seems the more comparable and the best model for the Earth. The dogs are not a good model because they lack the protective coronary collateral blood flow, and the primates have innate resistance to myocardial infarction that we have not in human. These large models are also many more expensive and difficult to work with due to the size of these animals. The rodent model are the first we use and the more developed and the more used, but there are the different variation between human and the rodent. We have a higher intrinsic breathing rate. We have a different isoform in the myosin. We have a higher cardiac basal metabolism and also different in electrophysiology. So the success of the therapeutic in animal studies, we have seen the success of therapeutics in animal studies, but they fail in clinical trials. So these animal models are not fully predictive and not so adequate for ischemic perfusion injury. So as it's the pathology that causes the most death in the world, they are extensively studied, but the data we have in the laboratory and in preclinical model fail to translate and to help the drugs to succeed in clinical trials. So we need to develop better in vitro and in vivo model. For that, new approach are under studied during the preclinical studies with controllable model and more predictive to the human pathophysiology. We have the tissue engineering reconstruction with human iPS cells, and also the use of iPS specific to the patient with some technique of tissue engineering to have more, to be closer to the reality, and also to take into account some comorbidity and the patient heterogeneity we have, which is possible with these cells. So for the future, what is clearly required and what can be the explanation of the fail in the transportation from the preclinical to the market. So taking into account the comorbidity, which is clearly a challenge, but is very important in this pathology. Also, this patient take not only one drugs, but there is concomitant drug. So it's important to take into account the interaction that can be lead, and also to develop a predictive in vitro model. So for the moment, we have the pluripotent human stem cell cardiomyocyte that are the more promising in vitro model. We have also tissue engineering and some bioreactors that are developed to mimic the circulation in the cells, which are also promising. And the challenge is to mimic the microvascular obstruction, because here it's not induced by atherosclerosis, but mechanically with ligation. Be able to take into account the comorbidity and also the co-medication or the more common co-medication. So I would like to thank you for your attention, and also to thank the FNRS, which is our financial support for these studies. So thank you.